The talk on angiosomes. So thanks for the panel and for the invitation to speak today. Most of this will be focused on angiosomes, then depending upon my mood, I'll share some ideas about pedal access. I have no relationships to disclose. Achieving complete resolution of wounds in patients with critical limb ischemia is one of the most challenging things that we face. And this is an example of exactly the problem. This is over 300 patients who underwent infrainguinal bypass. And at 6 months, only 42% of them had healed their wounds completely. At 12 months, still only 75% had healed their wound completely. And some of them actually died, 10%, with their wounds not fully healed. And there's a lot of factors at play when patients fail to heal their wounds. There can be problems with postoperative care. The extent of tissue loss can be so great that it really doesn't matter what's done. And then there's a number of patient factors, things like end-stage renal disease, patients who have malnutrition and low serum albumin, patients who are either on immunosuppressants or have a compromised immune response, and finally those with poor glycemic control. So here's an example of some of these patient factors at play. This is a series of patients, all of whom underwent infrainguinal bypass for Rutherford 6 lesions. And in the blue are patients without a lot of these comorbid factors, and you can see that at 2 years their amputation-free survival is actually pretty good. It's about 80%. But if you just add on end-stage renal disease, the green line, you can see a significant drop in the amputation-free survival. And if you add on top of that a low serum albumin, the 2-year amputation-free survival falls to below 40%. Now, another factor that may be at play is that maybe we're opening up the wrong artery. Now, traditionally, the plan of attack for these patients is just to try to establish inline flow from the aorta to the foot without regard to which vessels we're recanalizing. Could be the AT, could be the PT, could be the perineal. And yet we know now that 25% of patients with heel ulcers ultimately undergo proximal leg amputation despite having a pedal pulse. And as we've seen from some of this data, patients can actually have widely patent grafts and still fail to heal their wounds. So this leads us directly to the angiosome concept, and this was first developed and published by Taylor and Palmer back in 1987, and it's gradually infiltrating our thoughts within the vascular community. And an angiosome is defined as the three-dimensional anatomic unit of tissue that is filled by a source artery. Adjacent angiosomes are supplied by choke vessels, which in effect are collaterals, and it's possible that using angio-based revascularization may lead to better wound healing and also better healing of the incisions that we make for amputations and after bypass. These are the angiosomes of the leg. And you can see all the way to the left on your panel, anterior tibial artery supplying the shin and the dorsum of the foot, the perineal supplying the lateral aspect of the foot, and finally the posterior tibial artery actually has 3 territories that it supplies.